does the day, the next couple of hours. Thank you, Sarah, to make sure that we are going through and actually getting feedback from you guys on what you're finding beneficial. So please have that at hand, and please make sure that we're using our lovely Menti as we go along. I'm going to give it a couple of minutes just so that we can then go through and allow people just to log on, because conscious that it's just turned 12:30. And normally people are logging on or having issues with IT, as you always do, as we go along on that front. If I can ask you all to turn off your cameras, turn off your microphones on that front, as I've got someone who's decided to go. No, perfect, thank you. And I think our first lovely speaker is already here, and she'll be talking about kind of her research and what's going on there. And we will talk a little bit about our TNA as well. Hala, do you want to add anything?
Yeah, are we taking people's location, the borough, the PCN, where they're working, so we have a record of that? Or is it
so they can pop it into the chat if they wish, in case they didn't actually register and got the link from elsewhere. I am going to ask on the Mentimeter as well about what borough they're from as well, so that it covers us both ways that way, hopefully, she says. But if you have got a moment, if you can pop in the chat who you are, where you're from. It's not a dating service, I promise. And it will hopefully then just make it a little bit easier for our lovely record keeping team to be able to record keep. So I'm going to start with our lovely Michelle.
Oh, thank you, Tani. Hi, everyone. So I'm going to introduce myself. I'm Michelle. I work in St. George's as the lead education training pharmacist. You might have heard our previous conversation that I'm actually on mat leave at the moment, but unfortunately still need to do the research stuff. So hopefully the baby stays calm for the next 5 minutes. So I'm just going to briefly introduce the research that I'm working with University of Bradford. If for those of you who actually showed up in the, I think, July or August diabetes session. So I've mentioned it, that was when we were going through the ethics, and now we are nearly to the end and we're waiting for final approval for the ethics to go through. So we're going to be able to start the project pretty soon. So I thought I'll come on here and introduce the project again. So we are actually looking for some volunteers, PCN pharmacist, or if you don't work for PCN, that's fine. As a practice, that would be fine as well. So the project is about diabetes. So we're looking to see how we can improve or help our pharmacists to improve diabetes care in primary care, in the primary PCN setting. And there's 2 stages to the project. So the first stage, we're actually doing focus group. So to get the views of you guys, basically, on how the challenges or barriers that you've been facing during your diabetes consultations with your patients. And then we're going to go on to the second stage, where we actually going to develop a support tool for you guys and the piloting of the tool. So if you would like to get involved, you can get involved in either stage or both stages if you like. So the first stage is really just participating in a 1 hour focus group. It's across Southwest London, so we welcome anybody working in Southwest London in a primary care setting. Then the second stage is the piloting, which is more involved, but it's good, I guess, for your CV. If you would like some research skills, we provide the training. So you'll become principal investigator in your site, and so we provide the training for being a principal investigator, how you screen for patients, how you recruit patients, all that. We're going to do that for you. And so obviously I'm going to be the chief investigator. So anything that you need, you come to me. So if you're interested, then just drop me an email. I will send out the information sheet to Nisha. So thank you, Nisha, for disseminating that for me. And there's more information and details, and my contact is on there. Obviously the email, you'll see my email, the NHS net anyway. So we're looking forward to see if we got a few PCNs involved already. The last time I've got a couple more pharmacists who's interested in both stage. And so if you're interested, just drop me and then we can go through more details.
It'd be good if they add pharmacy.
Oh, could we just ask everyone to mute, please? Thank you.
I think someone dropped is it a question, Shani?
Let's have a look. No, people have just been writing in about where they're from, who they are and where they're from.
Okay, cool. Yeah, so just drop me an email if you're interested to get involved. That's it, really. That was very
amazing. Thank you so much, Michelle. We will cascade that information out so that you can get some more recruits, which is the way that we want to do it. Yeah. And hopefully that will then support you in trying to make life hopefully a little bit easier, she says, on that front. If there are any questions or queries, please feel free to put them in the chat, or please feel free to obviously put them on in itself, ask them yourself directly to Michelle when she sends out the information. And then we can go from there. But otherwise, nothing coming through on the chat, and I'm checking my phone as well in case I'm missing anything, because I've got the teams on here and I've got teams on there, and I can hardly ever see anything that's going on one and the other. So for that reason, thank you so much, Michelle, and your little one definitely behaved.
Yes, and I'm probably gonna have to log off pretty soon.
Oh, bless you. Well, stay as long as you can on that front. We were happy to have you.
All right, thank you.
Amazing, thank you. So that was a lovely little introduction from our lovely Michelle on that front. As you can see, welcome to the South West London Forum webinar in itself. So we are going and making sure that we're trying to make life a little bit easier, she says. And we like to start off with, let's talk. So if you haven't already and you don't know me already, where have you been on that front? So we like to get everyone involved. So if we try and get our feedback for our sessions through Mentimeter in itself. So all you will be doing is going and getting the lovely little Menti on the screen currently. You'd go and actually just join in itself using the barcode. So I'm just going to make sure it works, because I like to make sure that things work, she says. So you can scan the barcode or go onto menti.com and add in the code. So 46760363. And then hopefully, she says, it should work on that front, and people should be able to join, because we'll be getting in the moment feedback and getting feedback and stuff. So you could please just jump on and join on there as well. That would be great. Is everyone able to see that, Hala? Are you able to see that?
Yeah, I am.
Perfect. So it means it's working. So if you can join on to them and join on to Mentimeter, I mean, it makes my life easier overall, so we can get that feedback going on. And for those who haven't had a chance to go and write it in the chat, our first question, as always, is which borough do you work in? And essentially, which borough do you work in? Or are you hiding, essentially, that you are not meant to be here, but you're here anyway? So just go and fill in who you are, where you're from on that front. And it's nice to see it's actually working. I've got an other there for Michelle, because Michelle's on maternity leave. So if Michelle wants to join us, she can join on that way as well. But it just helps to give us a bit of clarity of where people are from to make life easier as well. So if you are new to here, if you can jump onto here, put up your name and who you are, where you're from in the chat. Otherwise, if you can just jump onto the Mentimeter as well and just let us know who you are, where you're from, it makes our life a little bit easier, she says. I will not reset the results because it causes all sorts of kerfuffle. But as ever, I always like to put a bit of a timer on so that it gives people enough time to actually be able to respond. But at the same time, goes and actually gives a bit of a deadline for when we need to get stuff done. Oh, I'm hearing an echo. Am I going mad, or is there an echo?
No, there was
stopped. It stopped. Amazing. Thank you. So we've got another 30 odd seconds.
The number of people on the call are more than the people who are responding to Menti.
Absolutely.
So it'd be interesting to know what's keeping the rest from responding to Menti.
Is there a reason people don't like using Menti? That's the question.
Can you still hear me? No. Oh, yeah. So it's working. Okay, that's good. Yeah.
So we've got easily about 30 odd people nearly in the audience. So if we can get those lovely 30 on the Menti, that would be great to give us that feedback. She says. She says. People don't like Menti, I don't think.
I don't know. I think maybe if they're using the mobile, it's a bit harder to jump between different.
I'd agree. Well, if you can pop in the chat who you are and where you're from, it makes
Yeah.
life a bit easier. Well, you prodding like that definitely made it easier going forward.
Yeah, see, people are responding now.
So, and if you haven't used it before, you're joining on menti.com and using this code at the top here. So it is 467603. I'm going to pop it in the chat. So if you can't get it that way, you can actually even go through the chat and jump on that way as well. So we've got a few more people joining in, which makes life easier. I'm going to give it another 30 seconds. She says. And just we're going to add in as well, we sent a training needs analysis out to everybody. So if you could please make sure that you obviously fill that in and give us the feedback. So of what you guys want, because we try and tailor these sessions to what your guys' requirements are. So we're hopefully trying to make sure that you guys get what you want out of these sessions. It'll be great to make our lives a bit easier. So please make sure you fill that in. It's completely anonymous. Just what we do ask, if you can write what area you're from as a minimum. If you can put your name and your details so we can come back to you if you've got any questions, that'd be great. Otherwise, you can fill it in anonymously as well. It does work, she says, on that front. Just write anon as your name to make life easier. So we are.
Sorry, if we missed out on any questions, if they have any suggestion, if you have any feedback, please put it on the
Let us
survey.
know.
Let us know. We do take every single comment, every single suggestion on board, and it helps us tailor the learning for the year ahead.
Absolutely.
So please answer or reply to the survey as soon as you can.
Right, I'm going to give it another 14 seconds. She says is the maximum I'm going to give it. I'm not going to give it any more. We've got an extra responder, she says.
Good.
So I'm going to leave that at that. So keep your Mentimeters on because we will be coming back to that to get feedback for the rest of the sessions. I'm going to stop sharing the Mentimeter, she says, and then start off with the session that has caused a little bit of a kerfuffle, a bit of confusion, I think, which is why we're doing it, about the whole point of AP v ACP. Yeah. So what are the different options for me? So Hala and I are going to go through it as two different pharmacists in two different paths on that front. But actually, what's the difference and how are we going to go through it to try and make life easier? I'm not going to give you an introduction to us because I don't think you need it, to be honest. But the key thing being is that we all saw the guidance that came out from our lovely RPS on that front. And it's led from the Post-Registration Foundation, which is the way they changed it, and a core advanced specialist, and then leading up to consultant level as well. So the idea would be is for us to progress from post-registration foundation all the way up. So a lot of us are probably working at that core advanced specialist level already, one way or the other. But it's kind of trying to figure out and navigate the area of where do I fit in? What am I doing to try and support my learning? And where do I go next on that front? Would you think that's right, Hala?
Yes, absolutely.
Perfect.
So yeah, we just wanted to touch base on to see where you are, where would you be interested, what's the differences, just to give you a bit of a, you know, an advice and guidance on the two pathways.
Absolutely. So in terms of both pathways, they both follow the same 5 principles, same 5 pillars. I don't know what it is, but NHS love to have different types of pillars on that front. So it's just what we tend to do. So in terms of the domain, we've got the person-centered care and collaboration and professional practice, which should be going and forming the base of our clinical practice in itself. Second one, next lot would be leadership and management. Fourth being education, and the fifth one being research, which is very difficult these days to actually try and put into place and do in primary care, but it's doable. It is doable going forward. And essentially, all of our practice that we tend to do is governed by these 5 pillars going forward. And anything you want to add to that, Hala?
No, I think we will come into it as we look into the individual roles and see how these work in a minute.
Absolutely. So when we're going, I like to just touch base with you just to make sure. So I think in terms of similarities and differences between an advanced pharmacist and advanced clinical practitioner, there's significant overlap between the expectations of an advanced pharmacist and those who are actually an ACP. Both of them are actually going and working at an advanced level of practice. So their experience, if you've been enrolled for more than a couple of years in primary care, most likely is you are either working in or working towards that level in itself. They're managing autonomously their own growing complexities encountered in healthcare systems, which is what we tend to do day to day. And actually, we're going and working across 4 pillars in itself. So that clinical one being the first one, which is split into those 2 sides, the leadership, education, and research side. And actually, they can deploy their expertise onto providing care for individual patients and demonstrate improved outcomes for the service that they support in itself. Now, when we're looking at these particular systems in itself, although they are very similar and they do have significant overlap, the 2 big differences that are going to come into this are going to be the first part being the expertise in the scope of practice in relation to medicines and pharmaceutical care. So as an advanced pharmacist, you've got an advanced level of expertise when it comes to medicine and delivery of care. So we're going to be working autonomously already and providing that clinical support and leadership in our roles already. So it could be that you're in a more senior role, could be that you're embedded in your role, could be that you're supporting others and you've got a pre-registration pharmacist who you're supporting through. But as actually in practices, we are leaders when it comes to pharmaceutical care and medical care for patients in itself already, and is working in that MDT team already, which we're doing in primary care. It's trying to mitigate those risks associated with the use of different medications and doesn't necessarily include management of undifferentiated patient lists. So it may be in specific areas, maybe in specific specialities, but it may be in all those different particular areas. Whereas in terms of the role of an ACP, it can actually vary, but generally tends to include deploying advanced clinical assessment and clinical reasoning, as well as the kind of the clinical support on that front. So you're going to be going and deploying all of the expertise that you've got in the role, as well as going and actually reviewing the things that are going and as being assessed on an acute basis potentially, as well as in a more enhanced physical examination side as well. So you're going to have that onset as well on that front. The role is not normally going to be explicitly linked to the background in itself. So it may be that it's just an acute setting that you tend to work in, an advanced clinical practice, but it's managed by a suitable clinician across a multi-professional team in itself. And individuals wanting to work as an advanced pharmacist usually have to demonstrate that they have professional specific capabilities defined by the RPS core advanced curriculum in advanced to a broader skill set required. And then that generally in a normal practice of patients in an advanced criteria. Hala, anything you want to add to that before I move on to the next bit?
Yeah, so I think it's important to understand why there has been this movement to advanced clinical practitioner and advanced pharmacist. Within the changes within the NHS and with having more professional clinicians going into primary care where there's more exposure to patients, unlike previously, it's important to meet the population and patient care and service delivery safety and effectively and efficiently, the contribution to clinical governance, each from their own perspective, and also attention to equality and diversity, inclusivity, kind of like issues. And that's why it was important for Health Education England to come up with the 2 frameworks. And if we look, hopefully at some point with the new CQC checks, if you're an advanced pharmacist, you need to prove that you have competency to practice within the advanced framework that you have registered yourself. So you have to have the evidence. With the ACP, it's different because you have a degree that comes with it. I hope that makes a bit of sense.
And I think that's exactly what I lead on to on the next part after this bit. So in terms of as an advanced pharmacist, we're looking at kind of the pharmacy and medicines expert as a pharmacy specific capabilities. The role would not be able to safely deliver another professional group. It has to be a pharmacist who does that. That's the key thing here. So a pharmacist would be advanced pharmacist, only be delivered by a pharmacist in itself. When you're looking at an advanced practitioner in silo away from advanced clinical pharmacist practitioner, or I should say advanced clinical practitioner who's a pharmacist, she says, general ACPs will be general assessment skills for managing undifferentiated patient lists, a generic role but drawn professional expertise. Role could be undertaken safely from individuals from a range of different healthcare professions in itself. And you will have those acute assessment sides as well, which would be looking at a more in-depth way of practicing as well. In terms of when you have one who does, you could have an advanced clinical practitioner who's a pharmacist, who is an experienced practitioner who does all 4 pillars in itself, delivers complex care, and actually merges these 2 different areas into one. So you can have a person who's an advanced pharmacist who's also an advanced clinical practitioner who's working across both cohorts on that front. And that follows on really nicely to what Hala was saying in terms of when we're looking at the difference between the two. To become an ACP, you need to usually have undertaken an academic master's level qualification supporting that develop an expected advanced level clinical skills, as well as the generic skills of the other pillars of practice. So in England, you have to complete the HE accredited ACP course. So that'll be with certain universities across the board on that front, which are recognised by the Centre of Advancing Practice. And it will focus on a broad generic range of skills, but you can choose to specialise in one particular area going forward. You don't have to be just purely generic like you would, for example, in working in emergency medicine or emergency care. There are now new advanced clinical practice courses which will specifically focus on one particular, so become a specialist in cardiology, in respiratory, and so forth on that front. So those are now emerging as time has gone on. In terms of advanced pharmacists, they demonstrate advanced level of pharmacy practice through the completion of the RPS Core Advanced program. So that's going to be through your framework, through the online e-portfolio route as well, to get a robust and independent assessment of an individual's vocational development, so what you're doing day to day in itself, and to get formal and how you are formally advancing in your education in the workplace in itself. You have to do this credentialing in order to be actually be qualified and be assessed as an AP in actual general practice in itself, actually across the board in any practice. And the ideal for this would be is to give you a solid foundation to work towards consultant level pharmacist practice going forward for those who want to achieve that going forward. There's nothing to say you can't do both. So for Hala and I, and Hala, do correct me if I'm wrong, I'm an advanced clinical practitioner. Hala is an advanced pharmacist, or working towards her advanced pharmacist if she hasn't got her credentials sorted yet on that front. But there's nothing to say you actually couldn't be doing both. So I'm an ACP, but I'm working towards now getting my qualification as an advanced pharmacist as well, because I'm sad and I decided to go and do the other one as well. Would that be right, Hala?
Yes, absolutely. So there is nothing saying that you can't do both. Now, the ACP is kind of like a generalized, I would say, master degree where it teaches you the skills and the competencies, how to develop yourself, whilst advanced pharmacist is you specializing in a specific area and then expanding and then starting another one. Each one has its own pathway. Each one can be registered with a different body. As I said before, is the Health Education England is trying to map out these kind of like, let's say, competencies, which helps with the workforce planning for primary and secondary care. And that's why it's important for you to be on a register, whether it's RPS or within you having the ACP master degree. So it's registered as your competency, as where you are at with your clinical and non-clinical expertise. And then that would help for the future. If there's any changes in the workforce, they know where you are at.
Absolutely. And I think that was why shortly prior to Christmas, I'd sent out an email to all pharmacists, pharmacy professionals across the whole of South West London about there's now funding via CPPE to get yourself recognised if you're already working at an advanced pharmacist level, to be able to help with the credentialing process as well. So the ideal would be is to add you onto there and give you support through their credentialing process. However, I found out myself as an ACP, I don't qualify because I've already done the masters, so I have to do it myself. But if you're not an advanced clinical practitioner, you can still go through this course, and actually they'll support you through that to be able to get qualified up as an advanced practitioner, advanced pharmacist in itself, to get you on there. The idea of this would be is that it then supports you going forward to go and actually get be noticed by the actual advanced centre of practice. Now, these are a bit blurry and I will send you out nicer ones, but essentially if you're an advanced clinical practitioner, you would get an A badge, which I very kindly have right now. If you would go down the route of going down becoming an advanced pharmacist in itself, you would then, and you're going through that via the RPS framework side, you would get an accredited program. So you would still be recognized as advanced by the Advanced Practice Center of Advanced Practice. However, you would get an accredited program. So it doesn't give you that autonomy in the acute clinical side on that front. So they are two different things. Now also for first contact practitioners, they have their own badge in itself. And for those who are aspiring to become consultants or speciality-led, there are two separate new badges they have come out with as well going forward to be able to show that actually these people are working at those specific levels. So it helps you to go and then distinguish exactly where you are in terms of your practice. And you can have multiple of these badges, I'm told, she says. However, it would make sense that the idea would be is to going towards having the more senior badge to the best of your ability. Would that be right, Hala?
Yes, I think that's absolutely right. So if you find yourself on any of those positions, you can look at the regulating body, contact them and see what is the best way of getting on the register and get the badge.
Absolutely. And what I have done to try and make life easier, I put all the references here because I'm sad. So if you want to read more about it in terms of the core advanced pharmacist curriculum, I've got that. And all for those people who just want the executive summary, the summary is there as well. For anyone who's interested in ACP in England, again, there is the guidance there, as well as what is advanced clinical practice. There is the link there, and that does link really nicely across to when we're looking at patients with advanced clinical, looking at becoming an ACP, there is funding available to go and get through both of these. Just be aware of the time commitment. There is a time commitment that you've got to put in yourself on that front, but it will support you then to go through these programs and advance. So there is light at the end of the tunnel. After CPPE, there is more that we can do to actually be recognized as clinicians in our own right, as advanced and more senior clinicians as well.
Any questions?
With that, I'm going to close the slide. And I do have, she says, I do have links to the different frameworks as well. So if that would be beneficial, I'm more than happy to put them in the email as well. So everyone's got a copy of the frameworks as well that you would need to work towards in itself. I think Dharani's got her hand up, I think, she says.
Yeah, hi, Chandni. Thank you very much. That was really useful. Just a quick question. Is there any support that work needs to provide you? Anything that they need to sign off?
So if you go through the framework, there will be certain different standards that you'll need to be looking through. The first thing I would say is have a look at the guidance, look at the standards. There will be, if you're going through this in itself, you'll need to be able to show that you've got an if you're starting from scratch, you'll need to show that you're have an educational supervisor, having a designated supervisor as well who can support that and back you for the actual process. If you're already working at that level, it's just showcasing that and actually going and imploring that and attaching what you're doing according to what the frameworks say. Have a look at the frameworks in detail first, and see what they're suggesting and see where you would sit in terms of your practice. What can you fill in and already show in terms of the frameworks in itself? ACP is obviously going to be something you have to do through a university, so it's not going to be something we're going to be able to do first and foremost. However, there will be for those people who are already working at advanced practice level, have a look at where you sit on that front, enroll for the e-portfolio route, and then that should then be able to support you going forward. The reason I haven't put the framework in here is because it's a 13-page document, and me going through 13 slides of the different portfolio routes probably isn't going to be the worth everyone's time on that front. So I would say on those reference links, because we're going to get this all sent out, on the full summary and on the executive summary, all the framework is listed on each page. So you can go through and see where you're sitting on there. Are you actually working at this level already, or do we need to start from scratch? And then you can plan how you're going to do it. But the full summary does say everything on there, exactly what you will need. So you'll need to get, if you're starting from scratch, you will need a certain amount of buy-in from an educational supervisor at work. But you don't need to go and have allocated time for it. You can cross-reference what you're already doing, if that makes sense. Does that help?
Yes, thank you so much. Thank you.
No problem at all. Any other questions? Okay, and now everybody will be aware we had our lovely Mentimeter on that front. If you've joined before I started, I need you all to join on to menti.com, use your code of 46760363. And I did copy, I think, across in our chat previously in itself. on that front. Oh, I think I've just seen another question. Are there any additional costs with being an AP? No, there aren't any additional costs. You would still be paying the same same GPHC fees. To join the Centre of Practice is just to as a directory. There's no charges effective with that as well on that front. So it will go make it easier for you. It's just about going and being acknowledged as an advanced practicing pharmacist. There's no cost as far as we're aware currently. If you get onto there now as well, there will be no costs going forward, we are told, she says. So for those people who need the code, it's 46760363. And you'll be joining our lovely mentee. And I'm going to turn on your responses. So how did you find our lovely brief session, she says, because it's very brief on that front. Did you have too much information? Was it just right? Can we go through it again? I'm hoping that I've given you guys enough information to let you know the difference between the two, because that was my idea behind it. We can go into more detail for those people who are aspiring to go down that route, but I think that would be maybe a different talk that we would do from maybe the monthly one. But feel free to let us know. The more people that tell us, the better. It makes our life easier on that front. So it's only 10 of you. Come on, people. Get on our mentee. So join on to the mentee.com. If you can't use the mentee, feel free to pop some comments into the chat and we can learn from there as well. On that front, so I think I'm getting a bulk of people have said it was just right. Some people have said it was too much information. Some have said it was too little. About the same of the too little and too much are saying that they need more sessions on the topic. But hopefully that's then given you guys a bit of a taster of what advanced clinical practice actually is and advanced clinical practitioner, because I know there were a lot of questions between what's the difference? Why do I need to have one and not the other? Or what is the difference between one and the other? So that hopefully helps to explain it. One is the master's route, one is the RPS accredited route. That hopefully helps to make life a little bit easier. So if you can keep going on that front, I'm going to put a little timer like I normally do. I like my timers. Pop it on for a minute. So if you haven't had a chance to answer, then it gives you a little bit of time just to answer and give us the information going forward. And again, like we did say in our TNA, so our training needs analysis that we sent out, if this is the area that you want more information on, put it in there in the other section, because we've left an other section there. You can put in there exactly what kind of training or education side that we can give you, or more information that we can go and claw together and get together. The framework will go and give you all the information. Oh.
Hi, okay. I'm fine, thanks.
I'm not sure who that is. Someone's talking. Nikki, I think you're talking, my love, but that's fine. I've got to mute her. So if you can go and just jump in and pop in onto there. I've got another 20 odd seconds before we tie up with our information on that front. And then I think we will be handing over to our lovely actual speaker for our clinical session going forward after this. Hala, anything else you'd want to add on this front?
No, I think you covered it nicely, Chadney. So again, mentee helps, the TNA helps, even emails helps. Honestly, whatever way you have to communicate with us, we look into it, we take it on board, we reach out if we want to discuss further. So please let us know.
So send us an email or send us a WhatsApp even if you want to. That works too. For any of those, a Telegram works too. That's why we've got the Telegram group. Use a Telegram group to start this conversation discussions off. If you haven't already, can you please pop into the chat? I'm pointing down there because I think that's where it is for most people. Into the chat, can you please pop into who you are and where you're from so we can go and collate that. And I can see our lovely Anne-Marie Logan has just jumped on, and I'm going to stop sharing my screen because no one needs to see my screen anymore on that front. And I'm going to let our lovely Anne-Marie to take over.
Thank you. Shall I share my slides?
Please do. You're very quiet.
Can you hear me at all?
I can hear you just about now. I can hear you just about.
Okay, all right. Okay, let me find my slides. Can you see my slides?
We can. They're not quite in the what's it called, in slideshow format, so that'll probably be what we need to pop into. We see them like a normal PowerPoint.
Can you? Can you see them in the PowerPoint?
We see that not as a slideshow, but we can see the slides.
Can you? Not as.
It's okay, we'll use it like this, but it saves time, Chadney. I think
Yeah.
sometimes it's an issue where it doesn't change into, do you have two screens, Anne-Marie?
I do, yeah.
So
Sorry.
it might be on the other screen.
Is it?
That you need to share the other
Sometimes
screen
happens.
potentially.
Yeah, but, I can, it's because I've got a set up with a laptop and a, can you
Okay.
see them? Is that going to be a pain for
We
you?
can see them
No,
clearly,
we can
so I
see
think
them
it's okay
fine.
to go ahead.
If
Yeah,
you're happy to
okay.
present that way, feel free to go ahead.
Okay, all right, if that's all right.
Absolutely.
Okay. All right, so thank you very much for having me. I'm really excited to talk to pharmacists. It's really good. I've been trying to talk to you guys for years. I'm really excited. I'm just going to go back a step. I'm the consultant physiotherapist in the headache service, and I'm co-lead of the headache service at St George's. I run the Headache Hub, which is is where all the GP referrals go into in South West London, in Wandsworth and Merton, and so we spend a bit of time trying to speak a bit more to pharmacists. It's become really obvious over the last few years how important pharmacists and pharmacy technicians are in headache, and so much so that we are about to put in some funding bid for an education package for pharmacists. So I'm particularly delighted to be talking to you. So really, I've got a question for you first, and because I can't see you now because I'm sharing a screen, can you just shout out answers to this, because I need to know from you. First of all, what headache conditions do you currently see, and what setting do you see them in? So I wasn't able to see what setting you're in, whether you're practice pharmacist, and I think you are, and what, with having us talk about headache today, what would you like the outcome of today to be? What help do you want to be able to give patients? So maybe you could answer quickly some of those.
Yeah, so I can, people can pop it into the chat and I'm happy to go and shout them out. I know that a lot of us are going to be all general practice, and we're all going to be general practice based pharmacists or primary care network based pharmacists, or pharmacy technicians for that matter. I've had someone say that we tend to see them during medication reviews. Some of them see us during acute clinics, if we're doing acute clinics. Someone has popped into here that we'd like to have advice about chronic medication overuse headaches. Another person's popped into here, migraines will be great, and knowing the prevention as well as acute use. I've also got people now texting me on my phone saying, she says, we would like to know what we can use after triptans for acute use. Fine. And
that's a really
anything?
good question. Yeah.
I think that's a question that I probably have as well, and that's a question I'll ask later in itself, because I get asked a certain question by lots of different patients on that front, with the change of guidance and lovely the news to do with that one. When to refer is one that's come up. So when to refer patients. What are the red flags that we should be considering?
Yeah. Okay.
Headache management guidelines and referral criteria. I think that's everything.
What was the last one?
Headache management, any guidelines that are out there, and referral criteria, and also what we should be referring in terms of to MSK specialists in our practices with respect to headaches.
Oh, great question. Okay. All right. Okay. I'm going to run, I think I've covered most of that, but please just ask if I haven't, and I'll try and speed through. How long have I got?
You've got till about 2 o'clock, so you've got plenty of time, don't worry.
Oh, crikey. 15 minutes to the whole of headache. Crikey.
You can
Okay.
take a bit longer, don't worry. Honestly, take longer if you need to. We're
Okay.
all here until about 1:15, where we've got the
Okay.
last speaker. So you've got time, don't
I'll
worry.
do my best. And
The other
and
thing I was
then,
going to say was, I'll be your eyes and ears in the chat. Would you like for me to ask you
right,
questions as they come, or would you like me to hold them till
yes,
the end?
absolutely. Ask me questions. Okay. All right. We'll speed through. All right. So this is what I was asked, but we will. I'll try and make sure I get through all your questions. So the guidelines bit, the British Association for the Study of Headaches is the place to go. And if you look up BASH, and it's BASH with one H and not two H's, otherwise you get sexual health, is where the information is. And I'll show you little pictures of relevant bits of the guidelines. But that gives you drug doses. It gives you places to go for education. It gives you videos. It's a really good resource. So if you ever want to learn more about headache, that's it's BASH in the UK. If we just look at the common types of headache, you've got three types. One is migraine, and that's 1 in 7 people. It's really, really common. And so if you're ever not sure, migraine is probably the diagnosis. Tension type headache is very common, but it's quite often poorly diagnosed migraine. And the reason for putting in cluster headache here is it's not a common headache, but you need to know about it because it's so severe. And so I will briefly go through that. So if we start with migraine, I don't want to teach you to suck eggs, but I will just go through it so we can go through the features. Migraine is a unilateral headache, although it often spreads to the other side. So if someone has a bilateral headache, it can very well still be migraine. It's a pulsing headache, but not always. It's moderate or severe. So someone who's got a very mild headache, it can be mild when it begins, but in a migraine attack, it's often moderate or severe. And it's made worse by movement, and it's accompanied by nausea or vomiting. But the nausea can be very mild sometimes. So it can be a queasiness, just prefer not to eat. You don't have to vomit. And the light and the sound sensitivity can also be quite mild. So a kind of top tip, if you're asking someone about it, is to say, when you have a bad headache, would you prefer that the lights are turned off? Or often what I'd do is just in the room with them, I would turn the lights off and say, when you've had a bad headache, does it feel better like this? And they won't tell you, they won't say I'm photophobic. They will just say, oh yeah, that's better. So if you physically show them that it's an easy way of getting that photophobia. And for phonophobia, would you ask people just to quieten down, or would you go to somewhere slightly quieter when your headache is bad? And that's the phonophobia they experience. So attacks are normally 4 to 72 hours, but this can be longer. And in episodic migraine, it is less than 15 days of headache, and I'll go on to explain how chronic and episodic goes. So it's very common. It's the most disabling condition under the age of 50, as rated by the World Health Organization, which is why we have whole services set up for it. But you'll see it in primary care, and it's 4% of GP appointments are about headache, and most of that will be migraine. So the interesting thing is a migraine attack. There's a really clever study where a woman called Laura Schultz took MRI images or MRI scans of a patient who had episodic migraine, and they did these images every day for 30 days. And the scan showed that before the patient actually experienced pain, which is the red bit of the ictal phase, they were already having brain changes. You can see in the pre-ictal phase. And so what the patient was already describing was symptoms of craving and heightened perception, changes in their light and smell and noise sensation, but they hadn't got pain. And I only bring this up because this is what people describe as triggers. They'll say that light triggers their headache, or that they had chocolate or cheese. But what we now think is the brain was already changing, was already in a migraine attack, but the patient hadn't already had the pain. And so it's not that the light was triggering it, it was already that they were having migraine, but they just didn't know it. And so a lot of these food myths and the things about triggers are not actually true. It's just that the migraine had already begun earlier. So episodic migraine is up to 14 days of headache or migraine a month. And then chronic migraine is 15 days of headache, of which 8 are migraine. And that's really important when we're getting to the drugs, because obviously NICE has allowed different drugs on different amounts of headache. So the acute treatment that you were talking about, we have some, I hope you can see there's a lot of information here. I've taken tables from the BASH guidelines that I spoke to you about. So the normal triptans that we would use, we'd start with sumatriptan, which is widely available. Everyone starts with 50 milligrams, but it's actually not that strong. It's the same strength as 3 aspirins. So the most important thing about triptans is the timing. So you can see in that ictal phase, the guidelines say that you should take a triptan at the beginning of the pain. So the triptans and the antiemetics should be taken together at the beginning of the pain. Now, interestingly, they should be taken at the beginning of the pain, but not at the aura. You can take an antiemetic such as domperidone or prochlorperazine or metoclopramide in the aura, but not the triptan and the analgesic. So say something like sumatriptan or zolmitriptan hadn't worked, you could try one of the others. Often sumatriptan gives patients a feeling of sort of heaviness, like someone's sitting on their chest. And so we might move on to zolmitriptan. And probably one of the ones that's got the least side effects is almatriptan or elatriptan. So if sumatriptan hadn't worked, I'd move probably fairly quickly onto almatriptan, elatriptan or rizatriptan, because they normally work pretty well. And I would do that on the basis of cost or side effects, choosing between those.
So Anne-Marie, we've had a quick question come through.
Yeah.
Are we able to advise on respect to patients who are above 65 years of age with respect to using triptans who aren't willing to stop? What advice can we give to those patients?
We almost always carry on. So if they're cardiovascularly well, we would carry on because the risk outweighs the benefits outweigh the risks. And so in our service, we don't stop anyone.
And if there is cardiovascular compromise?
Then you wouldn't anyway. You wouldn't be using triptans anyway, whatever age. So if they'd had a stroke, you wouldn't use them. If they had uncontrolled hypertension, you wouldn't use them anyway. So it's not about age at that point. It's about risk of the cause of their cardiovascular profile. So
okay, perfect.
It's not about the age.
Okay, so that, because I think the queries come from Ola very kindly, who said that actually, but the license is not over 65. They're not licensed, but we're still okay to use them above that age.
Yes, yeah. So we use them, and it's slightly unusual to continue having migraine at 65. You know, it does burn out in most people, but the people who it continues in have had migraines all their life by then. It's significant migraine, and so we would make sure that they're cardiovascularly well.
Mhm.
So you make sure that you're on top of their blood pressure and their cholesterol and everything else, but you would carry on with their triptans. So I
Fine,
think the
thank you.
practical way forwards is just to make sure that they were well, but carry on, because migraine can be really life limiting.
Of course it can, absolutely. Being a migraine sufferer, and I've only had a couple in my life, but they are horrible things.
Yeah.
And I've got another question that's come through. There are many patients who are on antidepressants, and there's normally advice not to use it in terms of concurrent use. What would be suggestion for those patients?
Yeah, yeah. So there's an article at the moment in the Prescriber about
Mm,
that. We carry on. So you might want to use the lower dose of the triptans, but I think everyone, yeah, we carry on. So I don't think any of my colleagues don't prescribe triptans because of it. We occasionally get patients who are really risk averse, or have a lot of anxiety, and are unwilling to have them. But I think there's rarely anyone who doesn't take it. Again, I suppose it's because the benefits outweigh the risks.
mm,
Um,
absolutely.
But I suppose since the advent of rimegepant and coming up with tolgepant, then we do have an alternative. So
And that was going to
yeah,
be something I was going to ask, because I think at the moment it's only St. George's who can prescribe that, she says. I think.
yeah, I know.
Um,
Yeah,
and
they're
it's a drama in itself, because we're getting a lot of patients who are having triptan failures who are asking for it. So do we know what the role will be of that? Or is there a
okay.
pathway going that way?
Yeah, so that's not decided yet.
Okay.
The consultation is still out and there's no answer yet. So you can have it preventatively,
Mhm,
and it's second in the pathway in Southwest London, second to Urenimab.
mhm,
So preventatively, it's therefore episodic migraine. But the confusing thing is that it's there for it's 8 migraines attacks per month. So so um, they've been a bit crafty, rimegepant, because they have done it for migraine attacks and not days. So a migraine attack lasts 4 to 72 hours. So it would be quite possible to have someone who's actually fits the international classification for chronic migraine, but has actually got could have rimegepant, because each attack lasts many days.
mm.
So it's going to be a bit of a navigation for us, but it's the prevention is only coming through us at the moment, and it hasn't
Perfect.
been agreed how it's going to happen acutely. So it's at the moment practices give out can't give out rimegepant acutely. What hasn't been decided, and preventatively we haven't prescribed it yet. Preventatively, because it's not the first option. We've got another option.
Perfect.
So I can't tell you at the moment.
That's fine. No, that I think that answers about 4 questions that I've had sent to me, so that makes my life easier. Because Vydura is unfortunately being asked by every patient ever since BBC News publicised it. And Natalie's very kindly written as well that only rizatriptan, sumatriptan, and zolmitriptan should be prescribed in Southwest London according to the formulary. Just as a reminder for everybody in itself, that we don't normally would refrain from almatriptan because it's non-formulary, but I'm sure that's something that could be discussed with medicines, with IMOC, if we need to go down that route and to update it.
Almatriptan works beautifully.
It does.
It really does. That's a real shame. The one other thing to say is that the 10 milligram dose of rizatriptan shouldn't be prescribed with propranolol. You can only use the 5 milligram dose. So just be aware of that.
Okay, thank you. That's all my questions up to date. So I'll stop asking now.
One other thing about provatriptan and naratriptan are really useful. So for menstrual migraine, they work beautifully. They've got longer half-lives and they're really useful for menstrual migraine. So they're a really useful thing to have up your sleeve if you need it.
Thank you for that advice. And I'll let you carry on. I'll keep an eye out again. Oh, and I've just had another one, sorry. So what about patients who get generally an attack that tends to last actually between 2 to 3 weeks? I would have thought that those patients need to be referred across.
Yes. So first of all, is it migraine?
Mm.
Well, actually, first of all, do a headache diary, because if they've probably got chronic migraine, and it's probably not the whole of that 2 to 3 weeks. It's probably several episodes. If you, I haven't got one here, but if you look at the migraine, the St George's website, our headache diary is on there, and you can download it. That would be the first thing to do. And within that 2 weeks, you could probably see little bursts of individual attacks if it's migraine. If it's not, if it is the whole 2 to 3 weeks, then really trying to get the triptan right at the beginning. So getting the highest dose, taking with an antiemetic, and taking it with a non-steroidal, the highest dose with stomach protection that you can do at the beginning, should be the most effective. But it sounds like a referral. Yeah, absolutely.
And I completely echo everything that you're saying. So I've done a bit of training with Naseef Mansour, our lovely GP with special interest in Kingston, and with consultant Ivy Yong. They swear by, if we can get some aspirin, 300 milligrams of it in some Coke, or cola, essentially the full fat stuff. If obviously if tolerable, and if they're not diabetic on that front, gets it into the system quickly and actually works really well to treat migraine, if tolerable.
Yeah, so the dose is 3 aspirins in something sweet, something with caffeine, and that and a triptan plus antiemetic, and that's about as good as you can do, really.
It works greatly on that front when I've had to use it.
Timing. It's about the timing, and most migraineurs will wait and see whether it's really going to be a migraine or not. And so they delay it for several hours. And so it's really quizzing them to see whether they've delayed it. And if they've delayed it and just taken drugs over many hours, you know that it's not going to be effective. So if you can get them to take it at the beginning, it becomes much more effective.
Perfect. And is there a role of Fisotofin anymore? Is another question that I've asked. And I saw that hopefully coming up on your next slide, so I'll leave that there with you.
Yeah, it's not really, a little bit. It works a bit, but it tends to be about our 3rd, 4th, 5th line, really. Women don't like it because it makes them put on weight, but it's a safe drug. It can help, but we definitely don't use it first line. It's used in children a lot, isn't it? And in adolescents. So there are definitely things to work better. This again is taken from the BASH guidelines. I have to say the favourite one is candesartan now. It just works brilliantly. It's so much better tolerated than propranolol. And even if you've got normal blood pressure, it just doesn't seem to drop blood pressure. And it just has so few side effects. We can get up to 16 milligrams pretty easily. And we'd want a patient to be on 16 milligrams for at least 8 weeks. And what you tend to see is that the migraine intensity just begins to turn down a little bit, and then the migraine attacks just space out a little bit. And it's just like a volume button. It just gradually starts turning it down. Probably the second favourite would be topiramate for all its problems, but it works really well. And the only 2 methods of contraception with topiramate are a coil or a depot injections. And once you've explained that they will get pins and needles, they probably will lose weight, and you counsel them on change of mood, and possibly change of mood and just possibly cognitive slowing. then if you tell them patients what it might be like, and get them to reduce the dose by 25 milligrams, and then reduce it again if needed, and then wait for a few weeks and then try and go up again by 25 milligrams. Once you've said all of that, you can generally get up to 50 milligrams BD, wait for a few weeks, and then see if you need to go any further. So that would be my next one. And after that, it would be amitriptyline or propranolol, sometimes nortriptyline. Pizotifen would come after that. Has anyone got any questions about that?
I think that it's been very well received on that front. There's a comment being made that clinicians are often cautious with aspirin in young children. So generally we tend to say the aspirin in adults, generally speaking, because of the risk of Raynaud's syndrome.
Yeah, sorry, I wasn't thinking about children. We're an adult-only service, so sorry.
That's absolutely fine. So the other one is, do we know, is it understood in terms of the candesartan, how it works for migraines? Do we have any information on that at all?
Yes, it's there's an enzyme in the pathway, and I've forgotten since I did my prescribing course what it is. I can't remember the name of it. Sorry.
It's fine. We can find that. Don't worry.
There's a yeah, I can't remember. Sorry.
That's fine. We will look into that and we'll feed that back on that front. Yeah. And also, do several migraine attacks go in generally affect memory and slowness in terms of in terms of the way that patients are able to react and reactivity, generally speaking?
Yes, they absolutely do. Yeah, so a migraine attack will give you cognitive slowing, absolutely. And it tends to be quite typical in some patients. So they will have a sequence of symptoms. They'll know that they'll get cognitive slowing, or they'll get balance problems, and it'll be quite typical for them. But the problem is, in someone who has chronic migraine, they may have that the whole time. And so they'll think they're getting dementia, or people with chronic migraine often have fibromyalgia and other long-term conditions. And so it can be really difficult to tell whether it's actually the topiramate or whether it's the disease. And there's often quite a high failure rate of our drugs in people with migraine, in the same way that people with epilepsy don't fail topiramate in the same way that people with migraine fail topiramate. And it's something about the disease, really. It's about people with migraine have a lot of anxiety, a lot of depression, a lot of chronic pain, in a different way than people with epilepsy do. And because of that, they need quite a lot of explanation, quite a lot of support to be on these drugs, and reassurance that it's going to be okay. And if you do that, and if you support them, then they actually can get up to the doses we know work.
Amazing, thank you. I think I'm just going to double check before I miss anything. I think that is where we stand on that front. So that is where we stand. Back to you.
So the monoclonals, we've got 3 of them. So irenemab, which binds onto the receptor, then we've got fremanezumab and galcanezumab. And then we've got the nerve blocks that we do in the hospital, so greater occipital nerve blocks and Botox. This is a bit old, so we've also got rimegepant, and then we've got a torgepant, which is coming up for its approval this year. The torgepant will be for chronic migraine. Is it? Oh, I can't remember. Episodic and chronic, and it will be headache days, but it's not out yet. So we talked about the problems with rimegepant. The 3 drugs that we've got, irenemab, fremanezumab, galcanezumab, we've got about 300 or 400 people on at the moment. Irenemab, fremanezumab, and we're about to start Galca. They work really nicely. So if you look at the trials that got them through nice, they are about 40% of people who were on those trials. It reduced their migraines significantly. So they, and that's about the same as Botox. So there's been no comparisons between Botox and donanemab or the CGRP medicines. And that's produced a bit of a problem in Southwest London in that you don't have we aren't able to swap between medicines. So if one doesn't work, if you don't have an improvement in one of them, you can't change onto a second CGRP. And if you've got a little bit of benefit with Botox, you can't then move on to, you can't just change and swap and think, well, I'll just go to CGRP. So we're not able to swap between treatments very easily at the moment. And that's really because there isn't the evidence to show that one is better than the other. So the CGRP medicines, they're once a month self-inject ones. We deliver them to the patient's house. And the side effects are fairly small. They're a small rash. There's some constipation, which is a bit more with donanemab and seems to be a bit less with fremanezumab. Apart from that, there's possible hair thinning, but it's been really very good. What tends to happen is the headaches tend to get worse until the injection, just before the injection date for the first 3 months. And then that gradually goes off in most people until about 6 months. And then after that, it becomes a bit more stable and we can start weaning the injections. But in about 80% of people, they need to carry on injecting. There's very few that we can stop doing these injections at all. And again, that's been a bit of a commissioning problem, but we're thinking about that. So in migraine, the things to watch out for, the people who don't do very well, are those who have a really high attack frequency, those who are obese, those who have some cutaneous allodynia, and that's a poor indicator. So if they're brushing in their hair and their scalp is really tender, they tend not to do quite as well. They've got high caffeine use or high painkiller use, or they've got psychiatric comorbidities. So those are the ones just to pay special attention to. So tension type headache, it's really a very boring headache. It's a pressing, tightening, non-pulsing headache. It's mild or moderate, but it's not at all disabling. It doesn't get any worse if you move around, and there's no nausea or vomiting. And it's a very bland one. It can last for days and days. We hardly ever see it in the hospital. And it's a bit of a red letter day for us if we ever see anyone with it. And you might wonder why they waited for months and months to come to the hospital. And there's often something else. They're anxious, they're worried about something, or someone's had a brain tumor in their family. So it might be in primary care, you might see them a bit more, but we really, really don't see people with tension type headache very often. And as I said before, it's normally undiagnosed migraine, and it's all about getting a really good history and a headache diary. And really, the treatment is low dose amitriptyline or acupuncture, and avoiding too many painkillers. And then in cluster headache, has anyone seen cluster headache?
I have, sadly.
Yeah, it is really truly awful. I might we've got 20 minutes, haven't we?
Yes.
I'm just going to stop sharing a minute and come back to you and just put on this. I'm just going to share again. I've got a video which might show you cluster headache better, which is which is the video of someone in a cluster headache attack. And it kind of shows you everything you need to know. See this?
This is Clarissa.
Can you see?
She's
Yes.
Yes, it's
just a
suitable.
headache attack. She hears loud ringing inside her head. Fire burning sensation ignites behind her eye. Hitting her head against a solid object to fight the pain. Oxygen helps steady her breath and keeps her from passing out. She injects herself with a sumatriptan pen. Her eye swells and droops. She may sometimes vomit after an attack. Cold water helps soothe the pain and discomfort. Extreme thirst and dehydration often follows. This is the first of many cluster headache attacks that Clarissa will endure today.
Okay, so let me just go back to my presentation. The major thing about cluster headache is how different it is from migraine. You'll notice that that she moved all the time, didn't she? In migraine, you sit quietly. You want to curl up in a ball. You want a dark room. You don't want any noise. You certainly wouldn't hit your head against a wall. Your head hurts. You stay quiet and still. Someone with cluster headache will move. They're agitated. They might go out for a run. She rocked all the time. The other thing that was completely different was that it was one-sided, and it was really one-sided. She held her head on one side. She held her eye, only her eye. There was a redness over her eye, and although she was vomiting, which can happen in cluster as well, it was so one-sided, and it was just over one side, but the intensity of the pain was just in one place, whereas in migraine it will be all over your head. So cluster headache comes on really quickly. It will start really intensely, and it's a series of attacks. So it's severe. It's between 15 and 180 minutes. It might happen 1 to 8 times a day. And what you saw in her was that you couldn't quite see in her eye, but you get this redness in your eye, a lacrimation, so the eye runs. Her nose might have been blocked up or running, and you could see in her that her face was sweating on that one side, You couldn't see the ptosis, but she might have had some eyelid edema. But she was getting this restlessness or agitation. But this extremeness of the pain is what makes people, we've had people being arrested while they've been in a cluster attack because they've become aggressive. The extremeness of the pain makes them move and not know what to do with themselves. As you can see, the treatment is sumatriptan injections and or zolmitriptan nasal spray or sumatriptan nasal spray. We would get, or you would get, oxygen, and a static oxygen cylinder can be got in primary care or it can be got from us. And although patients often feel that they need portable oxygen, the portable oxygen runs out really quickly. So it's as the cluster attacks are often at night, it's often better just to have a static oxygen cylinder. And really the question is, how long are the attacks for? So the attacks might be for 20 minutes and they might get 2 of them at night. So you're obviously going to need 40 minutes of oxygen. And the oxygen, you turn it up to 15 litres per minute, and they have a non-rebreathe mask. And so they would have that with their spray, their sumatriptan spray. But if the spray isn't working well enough, then we would get them to have an injection. And the reason why we're talking to pharmacists about this is because the attacks are so severe that the sprays sometimes don't work, and the injections are the only way to stop it. And the oxygen is there to help them while the injections are starting or while the spray is starting. So it is a really difficult disease to manage. So for patients who have cluster headache, if they're not under our care, then the plan is for you to refer them in if they think they've got cluster. You think they've got cluster headache, and the GPs do. There's the acute head or the headache pathway, which I'll show you in a minute. If they're in Southwest London or Wandsworth and Merton, they would come into the headache hub. The nearer Kingston, you go into Kingston or Croydon, saying you think they've got cluster. So what we would do is take a headache history, and one of the best treatments when they're about to go into a bout of cluster, which may be 4 weeks or 6 weeks, is to do a nerve block. And the greater occipital nerve block can stop a whole bout of cluster headache within about 3 or 4 days, and it stops it in about 70% of people. So the patients we have on our books at George's, what we do is get them to contact us. We have an email and a telephone number that they can contact us, and they say in the subject of the message, cluster headache. And all our clinical team know that we arrange a nerve block and a quick review to check that the headache hasn't changed, and then we do a nerve block quickly, and it can abort the headache. If that doesn't work, then we ask the GP practice team to start prednisolone, and if that hasn't worked, then we would go on to one of the bottom line here. So verapamil is the first line. After that, it gets a bit more complicated. So there's a stimulator called Gammacore. Apart from that, it's lithium, topiramate, melatonin. It all gets a bit more difficult. But so it's really about timing of patients who go into a cluster attack. Does anyone want to ask me a question about that?
No questions currently.
Okay, perfect. So she's a little bit unusual in that she's a woman. Most of this is in men. The cluster bouts come in the spring and the autumn, and that's because the disorder is in the hypothalamus, and it's got a timing thing to it. So we get, in the headache service, we get a bit busier spring and autumn around the equinoxes, and that tends to be when these bouts come. The bouts will be triggered by alcohol, by strong odours, by certain foods, and sometimes patients can have these interruptal pains. But patients with cluster can either have chronic cluster or they can have episodic cluster. The episodic cluster patients have these bouts of, as I said, several weeks. The poor ones with chronic cluster have attacks every day, but then they have, on top of that, they have superimposed worse bouts at spring and autumn, where they have more attacks at different times of year. And they should, of course, be under headache services or somewhere in neurology within the Southwest region. So if you're not sure, discuss them with your teams and get them referred in, because cluster headache is the most awful disease. So these were the acute treatments, and again back to BASH. This is what's in the recommendations, and the oxygen 7 to 15 litres, and they normally start with 15 litres and then they can turn it down after 10 minutes or so. The gamma core, which is this vagus nerve stimulator, has to come from us, and we can get it out to patients fairly quickly. And this is the nerve block that we do for as soon as we know that they're having a problem. And then the steroids that can be started probably 4 or 5 days later if the bout hasn't gone. And you can have 2 courses of steroids per year. And then the cluster prophylaxis is the first line is verapamil with ECGs at every dose increment. And this is our email address. It's headache@St George's if they need to contact us. Okay, so medication overuse headache was one of the things you wanted to know. So 80% of people with medication overuse headache have migraine. So if you had cluster headache, for instance, and you need to take lots of triptans, but you've never had migraine before, you don't have to worry. If you've had migraine before, then you probably do have to worry. So it's all really about the underlying headache. You're a high risk factor if you've had more headaches, obviously, and if you've had a psychiatric comorbidity, or if you've had a family history of medication overuse or substance abuse. The rules are, if you take a non-steroidal or paracetamol 15 days a month, or opiates, combination analgesics like anodine, or triptans on 10 days per month. And it's all counted on the days per month. So it's not on the number of tablets you have per day, which is what patients find really confusing. And so we have a kind of rule of thumb that if someone's having a headache, having difficult headaches on 2 days per week, then that's the time to be thinking about moving them onto prophylaxis, because then you get to the point where they're needing to take painkillers too often, and you're going to run into medication overuse headache. So the strategy really is explanation, and then if you think they're going to struggle, take time, encourage them to take time off work, get support from friends, and support them with antiemetics, because they will feel quite nauseous when they come off these. And then if they've had, before they got the medication overuse headache, if they've had a higher frequency of headache before then start them on prophylaxis early. And when you come off a triptan, you get a headache for about 3 days. If you come off paracetamol and non-steroidals, it's about up to 10 days. And opiates, it's a lot longer. It's a good 14 days, if not longer. You asked me about cervicogenic headache. Cervicogenic headache and neck pain. Unfortunately, you get pain in the same place, whether you've had it from cervicogenic headache or from migraine or episodic migraine, as you can see in the pictures here. So it's difficult to know whether to send someone with headache to an MSK service. It's really hard, and I say that as a physio. And I've obviously morphed in my career from starting to be a physio and then spending a long time being a physio and then moving into neurology and then doing a completely different job in neurology, and it is hard. So the International Headache Classification says that you have to have a headache that can be improved or resolved with a neck disorder, and you have to be able to provoke the headache by moving your neck or by something happening in your neck. So that essentially means that you have to have episodic headache. So it's really hard in someone with chronic headache to prove that your neck is responsible, because your head is hurting the whole time. And when you have migraine, for instance, 70% of people with migraine have neck pain. So if someone, the way to do it is if a patient didn't have, if they had a pain-free day, could they bring on a headache? And if you ask someone with migraine and say, could you bring on a headache? They'll look at you and go, well, no, not really, it just comes. Someone with cervicogenic headache, if you say to them, could you bring on a headache? They will go, well, yeah, if I do this, or if I drive, and if I do this, and my neck will be stiff, and then I'll bring on a headache. And it tends to be much more one-sided. It tends to be from the back and comes to the front, whereas a migraine will tend to be in a V1 distribution. It will tend to be here going back. It's not always the way, but it will tend to be. And if you really can't get the hang of it, and it just isn't making sense, get them to do a diary, but to also ask the physios. But I totally get it is really hard. People with cervicogenic headache tend to have less nausea and vomiting. They tend to have less light sensitivity, but it's not always like that. But really, you should be able to provoke a headache that comes from your neck. And it should at some points be clear. So it should be an episode of pain and then it goes off again. And if you think it's like that, then there are exercises to do and, of course, refer to MSK. So I put in here a whole lot of history taking things. And there is a background of headache is of migraine, for instance, of things like travel sickness, alcohol sensitivity, menstrual headaches, hungry headaches. And those all are very common in people with migraine. And if you're not quite sure whether it is, that's a sort of migraine phenotype. I think we'll have to whiz through some of these. This is the pathway in Southwest London. And so it divides out tension type headache, cluster headache. Cluster headache, for instance, would go to the rapid access services, the acute services, and migraine gets split into 3 types. So low frequency being less than 8 days, high frequency being more than 8 days, and chronic being 15 or more days. It says refer to community education. That isn't actually happening at the moment. We're thinking about starting it. But it's got some advice on each part about analgesia. And then the next page has got all the red flags. So these are the sort of amber flags about thinking about GCA, for instance, what you should do about postural headaches and exercise-induced ones. And then onto the proper red ones about thunderclap of less than 5 minutes severity and where you should send those. And those are, if you Google adult headache referral, it should all be there. And then just very briefly, in Wandsworth and Merton, the GP referrals come into the headache hub, which is 3 of us working to optimize medicines and really answer problems. So our problems are often that the diagnosis, you're not sure about the diagnosis, or the patient isn't, the medicine titration isn't working, or that you're not sure if they're refractory or not. And so we're not sure whether they need those specialist drugs like erenumab and those things, or that we've been using group clinics sometimes to help engage patients a bit better. And then just briefly, there's one referral form across the whole region. So if you do need the headache service, it's this form. And I think I was asked about advice or guidance. So the common, it's meant to be for patients already or not referred in, but we get patients who are referred in and we still answer it. So it's the queries we're asked about doses, about titration and how much to titrate, and asking us for protocols. About symptom changes, that's a really common one, and about diagnostic queries, and about the availability of the new drugs and what's happening now as new drugs come in, and about suitability of referral and medication overuse, and about non-pharmacological therapies, of which are a few, and treatment of hormonal migraine, things like probotriptan, naratriptan, and whether patients need a scan or not would be really common ones. Was there anything else on the list that I didn't answer?
I think you've answered absolutely everything that's on there, to be honest. You've done amazingly in that hour. So are there, with that, are there any other questions? I know that we went through a big flurry of questions when it was relevant, but are there any other questions that have come through on that front? I think the big question that I've had sent to me is, oh, I think I'm echoing. Nope, I've stopped. So the big question that I seem to be having is that with respect to looking at patients with the acute episodic migraines, we would carry on, and it's okay to switch between 2 to 3 different triptans. You don't have to just stick to the one triptan.
No, definitely not. You try it 3 times and then switch. Yeah, definitely. So there are triptan non-responders, and I think if you tried 3, I would stop. Yeah.
Because I think that's the thing. I think we tend to go and struggle with that, I think, in primary care, because then you're a bit stuck after you having tried the NSAIDs, having tried the triptans, you're like, what do I do now? And that's always a sticking point on that front.
Before rimegepant, I think we've probably carried on trying triptans till we've gone to all 7. But I think now I'd probably try 3. And because they have got slightly, I'd like to say flavors, but they're not flavors. They are slightly different. And in the BASH guidelines, it tells you about which ones to use. So there are definitely the menstrual ones, and there are ones with low side effects. So I would, if you can't try amitriptan, I would try rizatriptan or elatriptan.
Okay.
They do work
Perfect.
well. And
Well,
what you're saving is a referral to us.
Absolutely.
And you're saving rimegepant. So it's well worth it.
Absolutely. And you see rimegepant for people who actually really will need it in the end, who are stuck between a rock and a hard place, which unfortunately there are some patients who are in those positions. But it's about using it in the right patients rather than in everyone, is the way I would put it.
Yeah.
But you're okay for us to send you advice and guidance about dose titrations and questions and queries coming through on that front.
Absolutely. I'd love to receive them.
And can I just check something from my learning? So something I was told by, and I will check this because I had a particular doctor tell me about this, that especially if you've got a patient who suffers with anxiety, depression side, but also has migraines, significant migraines as well, they tend to find that using venlafaxine actually reduces down those migraines as well.
I was about to say, this has got to be venlafaxine, hasn't it? Yeah.
So I thought I'd just check to make sure that is there, because it wasn't on the slides. I thought I'd just check.
Yeah, no, venlafaxine does work. It's not in the guidance, but we use it a bit. Yeah, and it's also because that often happens around perimenopause, and quite a lot of our patients are going through perimenopause, which is why the migraines got worse. So venlafaxine can be quite a nice trick.
Amazing. So that's fine. I'm doing that. So I wanted to make sure I'm not doing something wrong for my learning. So I'm glad to hear that that still is something that does work, because patients seem to get on very well with it.
Yeah, no, it works nicely. Yeah.
Amazing. I think I have a feeling I already know what the answer is this, but would you be able to come back and do some case studies potentially with us about potentially looking at that?
Yeah, no, it'd be great. Maybe you could ask me, let's make it you prompted.
Yeah,
so you
absolutely.
Tell me what
We'll give you
you'd
the case
like.
studies.
Yeah, and I'll try and find some solutions. Yeah.
Amazing. Thank you so much, Anne-Marie. That's been really helpful.
Yeah, makes it better that way. Yeah.
Thank you so, so much. And thank you for offering to do that, because I know that there will be certain cases that I think we could all learn from in itself. So it's been really helpful and really handy having you here. There haven't come any more questions in the chat. I've been keeping an eager eye, and I've been keeping an eye on my phone as well at the same time. But if there are, I will definitely be dropping you an email and to let you know.
Thank you all. And I'm just going to put in our email at if you've got anything you need, you let us know. Okay.
Thank you. We're getting a lot of thank yous coming through on the chat, and I'm on my phone as well on that front. So very, very handy, very useful. Thank you so much.
All right. Thanks, everyone.
Thank you, Laurie.
Thank you.
Bye.
Bye-bye. And following on from our lovely Anne-Marie going and doing that talk for us, because I think that was actually really handy on that front. So if you haven't already, can we go back to our lovely mentee on that front? Because we know I like a mentee. Can we go and join on? So mentee.com, use the code 46760363. How did you find that session? Was that helpful? Was it not helpful? Was there a problem with it? Do we need more sessions on that? How did you guys find that session on that front?
Yeah, I think that was an excellent session. I think we have not touched on headaches before. So having such an expert with the different options of treatment, and even seeing that video, the cluster headaches, is insightful.
Absolutely. Well, I've seen that firsthand again so I think Lynette had written in the waiting room. I have seen that, and it's a bit kind of like you think, what on earth is going on? Is there a psychosis or something else going on with someone with the way that they're hitting their head? But actually, when you learn it all, it fits, and everyone seems to understand it.
And he was saying, do you know what's cluster headache? It's when you bang your head on the wall and you can't do anything about it.
And in a literal sense, in a very literal sense on that front. So that's about 13 of you. I know there's about 35 of you on there on this chat. So can I get you all on here and giving us a bit of feedback? Was there too much information? Just too little? Do we need more sessions? Is there more stuff that you guys want from us? So do you want more neurology based? Do you want more epilepsy side? Again, use that TNA that we've created to let us know, because would that be something that would be helpful for you? Because we can get people in to do the talks and give us that information if you tell us that. And hopefully that has been helpful on that front for everybody across the board. So again, so mentee.com, use the code 46760363. I do feel like I'm on a dating line, but I'm not going to say that out loud too many times. I'm going to put the timer on there for about a minute, just so it gives people to jump on and to give us that information in itself, because that helps us. And if you have joined afterwards or mid-session, if you can please pop your name and where you're from in the chat as well, just so that we've got it for attendance purposes, because I know that some people have attended via the link that I popped in the chat as well. So if you can do that, that would be great. Just so for record, for housekeeping purposes on that front. I've got house everything in my head at the moment, but that's a different story for a different day on that front. But hopefully
you will get the slides. Anybody who was registered for the event will receive the slides. Anybody who has not registered, they will not receive it. So that's why we ask for everyone to register so they can get the slides afterwards.
And also for the recording as well. So if you'd like to get that, then you'll be getting that through. But as long as we know who you are and where you're from. Otherwise, it makes it very difficult. We now have our final speaker for today, and I think that's Talut on that front. So my lovely Talut, who I'm going to actually lecture with at Kingston, will very kindly take over our last session, going and talking about pharmacy placements. And I think Claudette is also here to support and to give us a bit more input in there if we need it.
Fantastic. Thank you, Chandni. So I do recognise a few names on the list, but work very closely with Chandni when she helps us at Kingston. Amazing support. So I just introduce myself first. So I'm Dalit Saki, and I'm the placement lead at Kingston University. I've got a long career in pharmacy. Don't want to say how long, but it's at least over 30 years. So I've worked across most pharmacy care settings. And I did work in the old PCT world before you all amazing people came along and did all these wonderful things now, which is amazing. So we were right at the beginning when we were trying to get our foot in the door into GP practices. So an interesting time. But I've been in academia for about 16 years now. So I went from there to academia, very fulfilling. I have prepared a few slides. Tanya, I probably won't be able to see any questions. So do let me know if there's any questions.
I shall keep an eye. I'll be your eyes and ears. Don't you worry.
Thank you. Let's see if it's going to open up for me, and let me know if you can see the slides. Whoops, it's not showing. Is it showing the slides now?
It is. It's showing them in a presentation form, so you can jump between each one, not as a actual presentation, if that makes sense.
Okay, I'll do the slideshow. I should be on a slideshow now. My computer seems to be very slow all of a sudden. Is it showing it as a slideshow now? Is that okay?
Yes, perfect.
Perfect, perfect. Okay, so I have introduced myself. So just wanted to talk a little bit about placements. So Charlie, just correct me. You've got pharmacists and pharmacy technicians in the group today.
Across
is that right?
The whole of Southwest London, yes.
Yeah, perfect. Yes. So I was very kindly sort of invited by Zara and Nisha to come and talk to you, because this is an area we really need to expand on. All the universities across the country are working with GP practices. And just to give you a bit of background, so you're all aware of the new learning outcomes, so 55 of them to be precise, that the GPHC has landed on us. So these will go from the undergraduate degree all the way to the end of the foundation training year. So most of you would have seen that document, the Initial Training and Education of Pharmacists document. So in order to meet these learning outcomes by the end of the 4-year undergraduate training course, and to get them ready to come into practice and do their foundation training year, and actually then also use the same 55 standards, all the universities across the country have been developing new courses. And we are just about to be accredited for our new course, so fingers crossed. We've been working quite hard for the last 2 years, probably two and a half years on this. And obviously we have got we've got to fit in almost 6 weeks of placement. So considering what we currently, well, actually we've been expanding the placement program over the last few years since this came out, just because we needed to get ready for it. But we were probably doing about 17 or 18 days across 4 years in placement, which is clearly not enough. So we're going to something which is just over a 6-week model, which is probably what most universities around the country are going to do. And the course is going to be very much, obviously we all know pharmacies, it's a huge learning curve when you come into your foundation training year, but they need to be at a slightly higher level in terms of their prescribing attributes and being ready to prescribe at the end of that foundation training year. So we've done a lot of changes. I'll mention some of them in a moment. But you can see that what we're wanting to do, and what I'm quite passionate about, is giving them an experience in lots of different, well, the 3 main sectors, which would be community pharmacy, GP surgeries, and hospitals. And really that is to reflect how a lot of the placements in the future will go, where you'll have joint foundation training year placements, the split placements. So I think it's really important, students, also for you to secure the future workforce and for students to get an experience. We really need to have better collaboration with the GP practices, and we can talk about some of the barriers and the issues. But NHSE, HEE is now, as you all know, NHSE. We've been working quite closely with them as well, and I think they're going to be reaching out to all of the ICBs and the forums. So again, we're working with them as well to ensure that students do get all-round experience during their undergraduate years as well. Let me see if there's anything else I want to say from this slide. Probably not. I'll move on. So again, if we all know about the Miller's Triangle. So in terms of the course and in terms of that document, the Initial Training and Education for Pharmacists, the document has got certain learning outcomes. It shows how and some it does, and there might be a few knows how. So I think there's about 16 actually it does for the undergraduate level, and a lot more it shows how. So what we're going to be doing is developing the students. We've actually, so probably we're going to save this for later, but I'll talk about it now. We've actually got some funding from NHSE together with UCL and King's College University. So we're working as a consortium of the 3 London universities. And what we're trying to do is to have an e-portfolio which will be, so if you've got a student from any of the universities, it will look very similar. And this is to help you when you're working with us to sort of, you know, sign off students in their activities that they're doing. There's similar activities depending on the sector they're going to be at. So you'll see something that looks very uniform, hopefully. And we're using a lot of the assessment skills that are already used in the foundation training program, such as mini-KECs, CBDs, etc., DOPS. And what we're not wanting to do is make it onerous for the supervisors. So it will be more, we'll be doing a lot of this initial, so a lot of our courses change to simulation-based teaching. So they get a lot of as real as life as we can make it for them, teaching, and get them ready for those activities we're expecting them to do in the various sectors. And again, it's going to be, were they at an expected level, below, or did they exceed expectations? And that's, you know, that's how we're sort of looking at assessing them. And they have to produce their e-portfolio and their evidence, and then we will do the final sign off at the university. But what we're wanting to really move to a model of having students being effective members of the practice team. And I know you're all probably thinking, oh my God, it takes students like a couple of days just to get into their role and just understand it all. But because the placements will be for longer periods and we're going for continuous days rather than ad hoc days, and I'll talk about that in a minute, hopefully that will become a bit clearer. And hopefully if the students come to you in the 3rd year, then they may come back to you in the 4th year. So there's some continuity there as well. And what we're hoping is that this will be used, so that we want them to be useful, because what the GPHC want us also to demonstrate is they're not just observing things while they're in practice, they're actually moving to actually doing things, and that's really important. So just a bit of background. We, as I just said, we've got these, actually we've got 2 beautiful simulation suites now at the university, at the Penryn Road site. We've also got access to the simulation suites at our Kingston Hill site, which is the nursing midwifery site as well. So we've got hospital wards, we've got GP suites, and we've got a brand new immersive suite, which is hopefully going to be ready for next September, or coming September, I should say. So that will enable us to do some more interesting things, and augmented reality, play around with it. We're going to see how that works as well, and having sort of real life sort of noises happening when they're trying to be on a busy ward, for example. So that will be quite interesting. So happy for anyone to come and visit at any point. So our 1st and 2nd years, because the course will be very much for the first 2 years around responding to symptoms, law and ethics, and that kind of teaching, they will spend the first lot of placements in community pharmacy setting. So we've got sort of things that we want them to do within those settings. And then from 3rd year, what we're hoping to do is then to move students into the more, well, we're hoping the community pharmacy will also demonstrate clinical skills. But as their sort of teaching increases and they get more depth of knowledge in the clinical areas, which happens a lot around the 3rd year. So at the end of actually within the 2nd year, because the course is moving a bit differently. So 2nd year, they'll have a lot of the clinical teaching as well now. And by 3rd year, when they come to you, hopefully they'll be at a much higher level. And the other thing, what you must feel this as well, we find that we get feedback from providers or from the foundation training pharmacist programs that, you know, students are still from any university don't have those soft skills. So we're working very hard to develop those soft skills with the simulation type of scenarios, and the expanded time in placement hopefully will help with that. So they're going to spend 2 weeks, 10 days in a hospital setting, and also 10 days in a GP practice. And these will happen at 2 different times of the year. So this will give you an idea of what we're doing at Kingston. So hoping that will happen in October and in February. So they'll come for those 2 weeks. And we're going to work with the other universities. I don't know how many of the other universities you work with currently, but in London, obviously, it's UCL and King's. So we're trying to have a coordinated approach to this. And in the 4th year, they'll spend 20 days again in the community pharmacy setting over their summer. That's before they come to 4th year. And then they'll have another 20 days in an optional setting. So that might be where their interest lies. But because of this new split sort of foundation training program, we're going to allow them to have a split 10 days, but they have to spend at least 10 of those days in a hospital or GP practice and 10 in a community pharmacy. Another role of the Pan London project is around QA of the placement sites. So that's something that we're working to develop. So we have a central database, and we can say all of these pharmacies or all of these sectors or we'll say for GP practices or community pharmacies or hospital placements are going to be able to provide the necessary training for the students. And we're also looking at training all of the providers that we take on board. So and hopefully once you've had that sort of session, it will be much more straightforward. Just giving you an idea of some of the activities that we have. In the GP practice, obviously, we've got long lists. These are just some of the things we're hoping that students will be able to do. So we did pilot this, and I know, Chandni, you were involved in the pilot in 2022. We started that in sort of February till the end of July. And we sent students initially for 2 days into a GP practice and 2 days into a hospital setting, just to sort of trial some of our new activities. And we had some very positive feedback. But what we're hoping to do is that students start actually taking on a bit more of a role in the consultation, especially with the longer model. So we'd expect them to do parts of medication reviews, take drug histories, any medicines rec, anything once patients are discharged from hospitals, just making sure all of that's been reconciled. Looking at diagnostic tests, pathology data, and thinking how this might impact, obviously, the patient's medication. We heard earlier about migraines and the use of certain triptans not being in the formulary. So, thinking about the formularies and consider prescribing. So those kind of things, having those kind of opportunities for students to understand that within a real life scenario would be really good. Optimizing patient therapy, whether that's prescribing or deprescribing, being involved in the repeat prescription processes. And another thing which, again, you can advise me on this, but we're wanting them to sort of start doing some of those basic diagnostic assessments, because that's also part of the NHSE sort of requirements as to sort of meet the standards. So thinking of those basic diagnostic assessments, and it might be things like taking a blood pressure, a pulse, doing a peak flow or something, but just getting them to sort of start doing those. And that necessarily doesn't have to be with a pharmacist. It could be with another healthcare professional as well. And also attending, the different meetings at the practice, and maybe the pharmacist, whoever's with them, asking them questions a bit like you would have as a medical student, but getting them to think about, queries either from other practice team members or from the public or patients. So just giving you, this is just giving you an idea of some of our simulation sessions. So this is actually, so our degree is taught jointly by St George's and us. So they do spend time at St George's. We've got our own ward at the Kingston campus, but this is one of the wards that I used for a simulation session at George's. So it looks very real for the patients. And the patient here has got learning difficulties, non-communicative, so the students have to work out how to communicate with this patient who's in pain, and then trying to assess their pain management here. And this was sort of during COVID time, so just after, so we were a bit more careful. Another picture of students interacting with the role players. So these are role players that we hire, so students get to speak to people who are not staff and not other students, so it makes it more realistic for them. And at the bottom on the right, we've got this is actually our GP suite. So again, we've got a role player and the student having a consultation with them. Just to give you an idea, so of the value of the simulations that we do. So we ran a GP sim session to do with asthma, management of a patient with asthma. So it was a GP setting, and we had role players, and we did a pre-GP simulation questionnaire on Microsoft Forms, and then a post. And you can see that the students' ability to actually do these various tasks, there's a huge improvement. So the red parts are they strongly disagree, and the green are obviously agree. So actually their consultation skills greatly improved after the simulation session, and they felt more confident to do such a skill in practice. And their knowledge as well increased pre and post simulation as well, which is an idea. So some of the feedback after some of our simulation sessions, this is what students feel. which is really important to us. So again, this is an area where, as I said, we're expanding. So with the new course, we're hoping to start the new course, provided the GPHC accredit us, which we're hoping will happen. We're actually starting the new course in September of this year. We have already started embedding a lot of the new teaching into the course already. So we've already started increasing the simulation sessions from last year. And obviously we've already started expanding our placement programme. So this is some of the feedback from some of the students. And it's always lovely to get feedback from the GP practices. So this is some lovely feedback from some of the GP practices. And, you know, students are, we have students from all backgrounds. And, you know, we're hoping that with the new methods of teaching, you'll have a better quality of student, you know, and hopefully when they come to you in their foundation training year, then hopefully that will also make a big difference to you in terms of their skills eventually. I'm just going to move nearly there. Okay, so what I'm asking today, sort of, you've seen what we're hoping to from September onwards, the sort of placement programme that we want, and we want to work with you as our partners in developing that. But for this summer, we're doing a bit of transitional placement work, which would involve us sending the students post their exams. So this is the third year students. So they would have done a lot of, well, all of their clinical teaching this year. So all comorbidities, multiple comorbidities, thinking about it, we have a synoptic paper. So they have a patient with multiple comorbidities where they have to consider all of the medication, any changes that need to be made. So they are ready then to sort of go on these clinical placements. They have already spent this year 5 days in a hospital setting. And that's all going to vastly increase from next year. But to ensure that they meet sort of the new standards, we're going to run these summer placements, which will happen from the end of, towards the end of May after their exams. So actually the Monday the 20th, they're free from until the end of July. So what we're asking, what I'm asking is for people to come on board and take our students for 2-week periods in this time. So it will be 10 days. That is my email there. So I'd be really happy to sort of work with anybody. What we're wanting is for them ideally, obviously, to spend time with specialist pharmacists in those practices. But as I said, the programme can mean that they meet other members of the team as well, view prescribing from different perspectives. They could maybe spend time with a nurse prescriber as well, or a GP. I know that the tariff is the tariff. We've got the NHSC tariff, which isn't amazing, but that's what it is. There probably will be movement in the future, but there isn't very much we can do about that at the moment. But what we would say is, you know, these are your future workforce as well. Happy to work with anybody and develop the plan further. And we are talking to our stakeholders just to think about what's doable within certain settings. And that's me. Are there any questions?
No questions in the chat immediately. Claudette, is there anything you'd like to add in?
I was going to say thank you. That was a really timely update from a HIE perspective. I was in a meeting yesterday with NHS England Workforce Training and Education Directorate, and again from a London-wide perspective, and they were talking about some of the changes, and as from the GPHC, so now practices and health and justice sites will now be recognised as being lead employers for training sites. So that really helps in terms of developing cross-sector placements and looking at the competencies that are needed across the board. So that was really interesting. I've got your email, so I would like to pick up some things with you outside of that specifically, but I thought it was helpful to hear that. And again, any sort of linking in with the ICB, we've now got, we're undergoing a transformation, and our new structure comes into place from April, and we have within that a focus on how we can support training in general practice, placements, pharmacy professionals, so both pharmacists and pharmacy technicians in the primary care setting and how best to engage. So any thoughts around that? And so that includes our future pipeline and how we can help support getting more placements in place so that we have that security and sustainable workforce going forward.
Oh, fantastic. Yeah, no, I mean, it all sounds, I think everyone is moving in the right direction. I know we've all been landed with this thing, and now so, you know, I've had very positive from the practices that I've been working with, and I have worked with some of the practices here. You know, it has been very impactful on the students when we do sort of surveys post placement as well, which I haven't shared, but you know, they're learning, and that being in that environment will just, you know, be so amazing. I mean, we have our nursing school, and when I talk to them about, because they're in placement for months on end, aren't they? They just do months. It's very much hands-on experience, whereas pharmacists traditionally haven't done that. So it's a big mind sort of change that we all have to make as pharmacists, that especially in the working place, that actually you will have students with you most of the year now, and that's going to be the new norm. And I think it's about how we accommodate for that and how we change that. And I think as pharmacists, as a profession, we're very sort of careful. We don't trust the trainees, even, you know, the trainee pharmacists, let alone students. And it's changing that sort of shift. I think that's what you know, it's going to take time, and finding ways that we can look after the students without it putting too much pressure on the staff, be it in the hospital, GP practice, or community pharmacy, where they're actually useful, so we can get them to do certain tasks. And one of the things that in the meeting that I had yesterday with NHSE and stakeholders was very much, if you've got SOPs or if you've got certain e-learning you want them to do before they come to you, we can make sure they do that before, so that when they come to you, they don't have to then spend time doing it there, and they're more ready to carry on and do things. And we've got a prescribing system. So we've got System 1 now. We've got a demo version. I don't know if any of you use System 1 in Southwest London, but
I think most of us tend to use EMIS.
yeah, I know. I used to use EMIS, but that's the one we got a demo for. But it's, you know, it's just getting them to understand the importance of using a system, and how they have to be very careful when they're entering things into the system, but just getting used to doing electronic records and making sort of records. So, you know, they will have that higher sort of level, hopeful experience. And, you know, eventually I'm hoping they'll have smart cards, and that's another area we're looking at, so that, you know, they can have smart cards and have certain things that they can also do when they're on placements.
Amazing. Thank you so much, Talut. I have put up a little Menti on, in terms of kind of, how did you find the information regarding kind of the pharmacy placement? Was it relevant to your practice and actually something you want to support with straight away? Or would you like a bit more information? So I put it on there just so it gives us a bit of feedback going forward. And I think there's a bit of unsureness at the moment. If there is anyone, feel free to come and have a chat with me off here. I've done lots of placements for Kingston University, as well as a lot of the other universities, so it's an option, and happy to have a conversation. We've got one person who's happy to support the agenda so far, so I think it's about going and empowering those, because we remember how we were when we were going through the training curve, and placements actually really were helpful on that front. So I think it's one of those things that I think we need to be recognizing, that actually is supporting the wider workforce going forward. And I'm sure I'll be talking to Claudette anyway. And I work obviously alongside Talut in different ways, but again, we can help to hopefully support the agenda for our lovely pharmacy trainees going forward. I have had a question come through, is there any personal payment that comes along with being a tutor as such? Because it's a lot of time commitment for us as trainers on that front.
Yeah, unfortunately not. So there isn't, but hopefully you find the value of being part of that future, you know, workforce development. I know that's not ideal and it does take time, but what we're hoping is we'll have training sessions, and again, it will be, I don't want to put a lot of pressure on we don't, not just me, but we don't want to put pressure on any of the providers or any of the pharmacists, specialist pharmacists who work with students across any sector. But generally, you know, they have they have certain tasks we want them to do. Obviously, you are looking after them, so there does need a bit of planning. There isn't the extra money yet available, even on the tariff. We're not at the level we'd like to be at for pharmacy placements. That's unfortunate at the moment. So sorry about that.
Thank you, Taylor. And I think Claudette had her hand up.
I was just going to say, I'm not sure who asked the question. So it's not an individual placement, but if the PCN or a practice was to take on a placement, I'm talking about trainee pharmacies, not a pharmacy placement. So that has now recently been agreed, standardized across the sector, but we are talking about the undergrad placement, sorry. So excuse me on that one.
Yeah,
I think there is a certain tariff, I think, anyway, for the placements anyway, which gets paid to practices or PCNs anyway. But it's not the same rate as the undergraduate and the postgraduate, so the foundation year training. But there is a little bit of reimbursement that normally goes to the practice, but maybe that's something you could negotiate with them on that front. But I'm not getting involved in that conversation going forward. So we've got a bit of a split. So some people aren't sure, a couple of people who are happy to support, and a couple of people, or a person who's not quite ready yet. And I think that's the key thing. It's saying thank you for supporting us on that front and for being here today. I'm very conscious we've run over on that front. We will send out communication via all the regular avenues in itself. And just want to thank all of our speakers and all of the attendees today for making it actually a really interactive session and supporting everyone through the whole thing. Hopefully you guys have had something beneficial from today. I know the headache session has definitely given us all a headache a little bit, but hopefully you've taken something away and we can go and help the wider workforce going forward. That is me over and out for today. Hala, any final remarks?
Oh, I think it's been a great session with different speakers. Thank you very much, Dalush, for the eye-opener about what's coming ahead. Hopefully you'll have more pharmacists coming through to support you with the placements, especially this summer. And yeah, that's it from me.
Perfect. If anyone wants to get in touch about having a placement pharmacist, I've had one, I've had multiple, so feel free to give me a shout. But otherwise, I will sign off for today. Over and out, and we will catch up again next month where we have our talk on, I think we've got CQC and CKD next month, and we'll be going through the results of our TNA then, so that we can hopefully find out what you guys want more of next year. Amazing. Well, thank you so much, everyone. Take care. Bye-bye.
Thank you. Bye. Bye.